about growth modification. If we talk about growth modification, it means that we treat a patient who is still growing. Orthopedic treatment is a method of treatment for the younger patients. If we talk about treatment in orthodontics, we can distinguish orthopedic treatment. Here we have the growth modification, orthodontic treatment, so we only change the position of the teeth, and orthodontic treatment is for adult patients after 18 years old, and in this group patients needs not only orthodontic treatment but also surgery. Orthopedic treatment. If we know that we have this kind of defects in orthodontic, like transverse, anterior, posterior, and vertical defects, in transverse defects we have problem with narrow maxilla. So we will treat patient with expansion. In anterior, posterior defects, we distinguish here class 3 with underdevelopment of maxilla, which we can treat very early and influence on the position of maxilla to lower jaw, and treatment of patient with class 2. Vertical defects in this situation, we treat open bite and deep bite. Now, transverse defects, cross bite. Patients need skeletal expansion of maxilla. In this way, we can treat the crossbite. What kind of appliances we can use when we are planning expansion of upper jaw? The type of appliance depends from the patient age. And for example, if we have younger patient till 10 years old, we can use for expansion removable appliances like upper plate with the screw in the middle. You should know that if we turn one time, if we activate one time the screw, we achieve 0.2 millimeter expansion. So we ask parents to activate this kind of appliance usually 1 time a week. And we ask child to wear this appliance all the night and few hours during the day. And next group appliances are fixed appliances. In this group we have quad helix and Hyrex. Quad helix is also appliance which we can use for skeletal expansion. What it means, skeletal expansion? It's expansion when we open the palatal suture. So we don't influence on teeth position, but we open the palatal suture. And we can open this palatal suture with quad helix when the patient is also about 10-11 years old. When the patient is older, rather we are planning the treatment with Hyrex. Hyrex you can see here, it's also fixed appliance. We will talk about this appliance more during the lecture, but this appliance could be used for younger patient and for older patient. But sometimes we can use only this kind of appliance. Sometimes we also need operation before this kind of treatment. If we use quad helix, we can achieve expansion to 6 millimeters. If we use, usually it's 2 millimeters per month after activation. Hyrex, we can have screw which gives us expansion to 7, 10 millimeters, and the biggest screw is about 12 millimeters. Usually we use screw 7 or 10 millimeters, which give us 7 or 10 millimeters maximum expansion. Now we will talk about clinical cases in transverse defects. So if we have narrow maxilla, usually we have a problem with crossbite. So before we start treatment, we should know how big expansion that our patient needs. So what we should measure. During our lesson, we talked that we should measure the posterior width of upper arch and posterior width of lower arch. We can do it from central sulcus of first upper molars and on distal cusps of lower molars. You see that this cusp of lower molar has a contact with this sulcus of upper molars. So this is correct position. So this width should be the same. Here we can also measure different points, but during our labs, you studied that we measure these points from this part to this part in upper arch and from upper distal cusp of lower first molar on one side to the other side. And these distances should be the same. If upper arch is narrow, usually we have 5, 6, 7 millimeters discrepancy. It's for us information that our patient will need expansion 5, 6, or 7 millimeters. Now, expansion we always make with overcorrection. So we should remember to add 2 additional millimeters. So the discrepancy is 5 millimeters, we add 2 additional millimeters, so we need the screw 7. If discrepancy is 6 millimeters, we add 2, so we need screw 10 millimeters in Hyrax. And we ask patient to make activation of this appliance. It depends what kind of sometimes we have rapid activation or slow activation. Rapid, it means that we ask patient to activate this appliance 2, 3, even 4 times a day. So it will give from a half to even 1 millimeter activation per day. It's rapid activation. Slow activation, it's about 1 turn per day, so it gives about 0.2 millimeters. So we can count how many activates should parents do for in this appliance. And of course, we ask them to come to our office. We want to check if it's correctly done. Okay, but I told you earlier that palatal suture, this is the screen from the CBCT. Here you can see palatal suture on each one. And palatal suture could be in stage A, so it means that this is a very young patient. We can open this palatal suture, there's no problem. In stage B, it's more difficult to open, but still is possible. So we can use Hyrax or quad helix. In stage C, this is the stage when we can still think about opening the suture with appliance like Hyrax. But in stage D, you see that there is no suture. So here it means that in this situation, the expansion is impossible. So we should to think to ask the surgeon to help us, help the patient in this procedure. So what usually the surgeon should to do, it is cutting leopard 1, and of course the patient still wear the Hyrex. So in these two stages, the expansion is possible, but with help of the surgeon. So we call this procedure surgery assisted rapid palatal expansion. Okay. Here we can see how to estimate the stage of maturity of palatal suture in CBCT examination. And our patients now, first patient is a 10 years old boy with unilateral crossbite on one side, as you see here, and we have mixed dentition. The same patient after treatment, you see that we have correction on the molars. We start the treatment when patient has mixed dentition. We use quad helix. Why quad helix? Quad helix because the appliance this has 4 helices and bands on first molars, and here is the wire. After expansion, after exfoliation of the deciduous, premolars, deciduous molars, and eruption of premolars. And how this appliance work? This appliance could be fixed in patient mouth. We use usually glass ionomer with in activation. So we put appliance which is activated before placement. Usually, we don't remove during our visit, when the patient comes to our office on visit every mouth, we don't remove this appliance, but we activate it in patient mouth. What we use? We use other instrument. It looks like this. And if we want to achieve activation on this level, we should to bend this part of wire like this. If we want to activate this part level from canine to first molar on one side, we activate this wire. We bend here this wire. If we want on both sides, we activate here. So here we have expansion not only on molars, but also on canine, premolars, or deciduous molars. If we activate here, we have only activation on molars, always on both sides. Here, we can achieve activation on one side. If you read this, you see that this is unilateral crossbite with mandibular deviation. What does it mean, mandibular deviation? Look at this patient before treatment. You can see that we have a little asymmetry. The Pogonian point is here, PG point. On this side was crossbite. That's why the lower jaw go on the side where is crossbite. And we have a little asymmetry. If we don't treat this patient before the spurt of growth, we can expect that he will grow still with asymmetry. And after finishing the growth, so in group of boys it's about 12, 13 years old. In this time is the spurt of the growth. So this boy will finish with asymmetrical face. And of course, we still can treat the crossbite intraorally, but as we will have skeletal asymmetry, so we couldn't influence on this with only orthodontic treatment. This patient will need operation in the future after 18 years old. That's why it's so important if we have the patient with crossbite and mandibular deviation, we should treat this group of patients very, very early, as early as is possible. Also, if we have patients with expansion, that it's a good idea to treat this patient earlier because it's easier to open the palatal suture and it's easier to achieve skeletal expansion of this patient. OPG of this patient before treatment, and here during the treatment fixed appliance, you see that this patient has also incorrect position of incisor. That's why, and there was the traumatic bite. I put 4 braces on the central and lateral incisor and bands on molars. We call this appliance 2 on 4. We can use it when we have younger children with mixed dentition if we need only correction of this group of teeth. This patient doesn't need the treatment in the future after eruption of all permanent teeth. He don't need next correction. Next patient is 10 years old girl. She has also crossbite, as you see here, is bilateral crossbite without mandibular deviation. And the same girl after expansion. Here you can see her arch before treatment, mixed dentition after treatment. When I remove this appliance, I remove it with a few deciduous teeth. It's normal situation because if we treat the patient with milk dentition, very often we observe faster resorption of the root of this deciduous teeth. If we have patients with mixed dentition, very often, if we use Hyrex, we use acrylic splint from canine to first molar. And how this appliance work. This is a Hyrex in permanent dentition, and this is the key. You can see how to activate this appliance and what happened. You see that after activation we have a huge diastema, and this diastema usually closes after a few days. So if we see clinically the diastema, it's very good information for us because it means that the palatal suture is open correctly. And this is the same girl. You see her face before treatment and after treatment. It was symmetrical. PG of this patient, you see there was incorrect position of the canine, but if we are planning in the treatment huge expansion, usually we don't need extraction of canine and deciduous molars because if we have more place during this expansion, which we achieve, usually the canine change the position and erupt correctly. I don't have probably I don't have the picture of this patient, but there was no problem with eruption of the canine, and she don't need the next stage of treatment with fixed appliance. So there was a little incorrect position of a few teeth, but it wasn't the problem to such a big problem to start the treatment with braces. Next patient is 12 years old girl, and if you look at her, you see that she has a bilateral crossbite without mandibular deviation. Also, we don't see it here now, but on the face we can check that there was no mandibular deviation, and this girl has also underdevelopment of upper jaw, proclination of incisor in upper arch and retroclination in lower one. A little crowding. In upper arch, there was also a lack of space for the canine, the tooth number 2, 3. But we can see that this tooth was here in the bone. So with an expansion of upper arch, the shape of her arch before treatment, you see no space for canine. During expansion, we use also Hyrax, but we use Hyrax with bands. If we use bands, we put these bands on the first molars and usually first premolars. So after expansion, this canine start erupted, but in vestibular position. So I put the braces in upper arch and pull this canine into the arch. But you can see here a huge calcification, demineralization of teeth, because this girl has very poor hygiene during treatment with braces. And as I told you earlier, she has skeletal class 3 with underdevelopment of upper jaw. That's why I don't put the braces in lower arch. She will need correction and operation when she finish 18 years old. Of course, it will be her decision. If she will decide about orthodontic treatment, she will need once again treatment in both arches with fixed appliances with braces. Now we'll talk about anterior-posterior defects. So here we have treatment with maxilla protraction. So treatment class 3 malocclusion with maxilla underdevelopment, and class 2 malocclusion here in this defect we want to achieve advancement of lower jaw. Face mask, extraoral appliance for growth modification, and next appliance, functional appliances for treatment class 2. Clinical cases, class 3 with underdevelopment of maxilla. What you should know, that this treatment is possible when the patient is under 10 years old. The zygomatic suture at this time is still elastic. We can open this suture and pull maxilla forward. Cephalometric analysis of this patient, you see that we have problem only in upper arch. SNA is smaller, SNB is correct. So we have, if we look at A and B value, we have skeletal class 3 with underdevelopment of upper jaw. How we treat this problem? So we use face mask. Face mask, this is petite face mask, is, as I told you, extra oral removable appliance. This appliance is connected with appliance which is in patient mouth, fixed by elastics. So we connect this part of the appliance with the hooks on the intraoral appliance. Here you see Hyrex. Why Hyrex? Because very, very often the patient with underdevelopment of upper jaw has also problem, not only anterior-posterior problem, but also transverse problem. So first, this group of patients needs expansion and then protraction of upper jaw. If upper arch is correct and the patient don't need expansion, we can use a special kind of construction for face mask. So in this place is no screw, but we have some kinds of construction. Here is usually wire, so it looks very similar, but here we have wire. Very often also, if we have patient with mixed dentition, we can use here acrylic splints, and the hooks should be on the level of premolars, first premolars, or first deciduous molars. This position is not correct. Okay. If we look at this appliance, we have this appliance. It has 2 points of anchorage. So first is forehead, and next is chin. The forehead is stable, but here the mandible is not stable, it's mobile. So if there is a power with this direction, backward direction, because here is the power in forward direction, we can expect distal rotation of lower jaw. So this is a kind of side effect which we expect when we treat the patient with face mask. So this appliance will be very good appliance for patient with correct lower part of the face or shorter lower part of the face. In group of patients with longer lower part of the face, so in group high angle patient, it's not a good idea to use this kind of appliance, or we should be very, very careful if we make decision about this kind of treatment. Okay, now how works this appliance? Young patients wear this kind of appliance at home during sleeping. So we ask patients to use it from 12 to 14 hours per day. And the treatment should be finished before 10 years old. And this girl was treated with Hyrex and face mask, superimposition of the cephalometric X-ray. Black color is before, red after treatment. And look what's happened skeletally. This is maxillary bone. So protraction, distance, so forward movement of the upper jaw. It was not huge. Usually we achieve from about 2.5 millimeter of protraction of upper jaw. But what's happened? Why the effect is so spectacular? Because we have a little protraction, proclination of upper incisor, retroclination of lower incisor, and backward rotation. You can see here, black, red, backward rotation of a lower jaw. So when we connect all this effect, we see this kind of effect when we look at this patient, at this girl. Next problem is anterior-posterior defect, class 2 treatment. Class 2 we treat with functional appliances. We will talk more about functional appliances during 9 semesters. It's also kind of growth modification, because you know that in class 2 we have distal position of lower jaw to upper one. So what we want to achieve during our treatment is advancement of lower jaw to correct position. This is our patient. I hope that you recognize that this patient has class 2, division 1. Why division 1? Because we have protrusion of central incisors. Look at the overjet, is huge, but what's atypical here? You see, we have scissor bite on both sides. What it means? That the upper arch, class 2 division 1, is wider. In normal situation, you know that typical for class 2 division 1 is a very narrow upper arch, V shape. Here the arch is V shape but is wide. So this patient is a little different than the normal group of the patient with class 2. And here you can see the overjet is also huge. Okay, S and B is smaller, and A and B value is 5.1, so it means that the patient has a skeletal class 2. Also, you can see there is huge protrusion of upper and lower incisors, but the patient has also some spaces between this teeth. Okay, you should remember that if we are thinking about functional treatment, class 2, it's very important to start this treatment when the patient is in the spurt of the growth. What it means, the spurt of the growth. So we are waiting for the most intensive growth of all the body, because the scientists found that the intensive growth of all the body is in correlation with intensive growth of lower jaw, and is the best time for treatment. If we look at chronological patient age, it's usually when for female for girls is the age of 10.5, and for boys it's the age 12.5. So 2 years later, we should start the treatment of boys. But you know that it's in this way we couldn't exactly estimate, if you look at the chronological age, the true patient skeletal age. To estimate skeletal patient age, we should to look at the shape of vertebra. I hope that you remember our first semester cervical maturation stages from 1 to 6, and the best situation is if we start the treatment at this stage 3. So concavity on the second and third vertebra, and here this vertebra is still flat. we should to finish the treatment at this stage. So here we expect the most intensive growth. Okay, the most popular appliance nowadays, which we use, is twin block. Twin block, it means that we have two plates for upper arch and lower arch, and here we have blocks of acryl with inclined biplane. So if the patient closes the mouth, this lower jaw goes forward. To prepare this kind of appliance, to make decision about functional treatment, first we should to check if our patient could advance the lower jaw to the correct position. So our patient has class 2 cusp, and we ask him, please take your lower jaw forward, and we check if the contact on the molars should be in class 1 or the contact on the incisors sometimes should be in edge to edge. We see that and if intraorally this situation looks better, and also extraorally when we look at patient profile, when his profile is also looks better, is for us information that we can treat this patient with functional treatment. We can give this patient functional appliances. So if we have this correct position, we should to put between the upper and lower tip a part of wax, and we take functional bite. In functional bite, we have correct position of upper jaw to lower jaw. And then we ask technician to make for us appliance in this new position of upper jaw to lower jaw. Here you can see this kind of appliance. We have a lot of functional appliances. You will study about these appliances at 5th year. But this kind of appliance is nowadays the most comfortable appliance. That's why I'm showing you this kind of appliance. Okay, and how it works, this appliance. You can see that this appliance has, you can see here is the screw in the middle for expansion. Why? You know that usually the patient has a problem with very narrow upper arch in class 2 division 1. So if we take lower jaw forward, usually we see crossbite in this new position. That's why patient needs expansion of upper jaw. We remove here acryl, and then we have also correction of deep bite. Usually patient after the first part of treatment with removable appliance, as you see, needs correction of the teeth with fixed appliance with braces. A different situation we have if we have class 2 division 2. In this situation, before treatment, usually we should to change the position of incisor to the correct position. Usually we use braces to do this, and then if we achieve alignment of the teeth in upper arch, we can take functional bite and prepare this kind of functional appliance for patient. So the patient needs 2 stages of treatment. Usually, functional appliance patient wear for all the night and minimum 4 hours per day. This kind of appliance, twin block, the patient can wear for all the day, 24 hours per day. He can speak in this appliance, he can eat in this appliance. And the time of treatment usually is 9 months active treatment, then 6 months for a passive treatment for retention, and then we put the braces. This patient, after first stage of treatment, in first stage we achieve full correction on one side, as you see, class 1, and here we have class 2, cusp to cusp. It's a very common situation. Very often during treatment with functional appliances, we don't achieve full class 1. That's why patient needs the next step of treatment with fixed appliances. And here after full treatment, so twin block, braces, TPA, it's transpalatal arch, because the patient has also rotation of first molar, and class 2 elastics. The most important in functional treatment of class 2 is the patient profile. Look at this profile before treatment and after treatment. Look at the sulcus, look at the position of the chin, and also very often we observe that this part of the face after treatment is a little longer. Now, vertical defects, open bites and deep bites. Open bites, how we can treat? We can treat it with intrusion of upper first molar, or deep bites we can treat with extrusion of upper first molar, or stimulation for eruption lower molars and premolars. Headgear. Headgear is appliance for treatment deep bite and open bite. We can use it because we have 3 kinds of headgear. It's removable extraoral appliance. So in this group of removable extraoral appliances, we have face mask, headgear, and chin cap. Chin cap we don't use very often. The most often still and the most useful appliance nowadays is still face mask, because why headgear is not as useful as earlier, because we have micro screw, micro implants. That's why more often we use this kind of method for treatment, open bite, than headgear. We can expect better result because in this situation the motivation of the patient is not so important. Okay, skeletal open bite, growing patient. Look at this patient. We start the treatment in this situation. High pull headgear, you can see it here, is the part of which is wearing on the head. Here we have intraoral part and extraoral part. This extraoral part we connect with the straps, and here are elastic. So here is the power, the force, and because this part creates the force. Look that here we have U-bend. For what is this U-bend is very important. If we don't have this, in this part we should bend by ourselves this. And this part we put here. This is activator. It's a functional appliance, removable functional appliance. We put this into this tube, and it gives this kind of direction. It works like this. So it pull molars and all backward buccal tip up. It push it up. So we want to achieve intrusion of not only molars if we use this kind of appliance, but also all this part of the upper arch. Okay, we could have also this is high pull headgear. We could have also low pull headgear, and this part is not here but here on the neck. And then the force direction is down, so we make extrusion upper tooth, like first molars, from the bone. So we pull it out. When we treat deep bite, we use low pull headgear. We want to achieve extrusion of molars. If we treat open bites, skeletal open bite, we need intrusion of molars to close the bite. How we can achieve it? Because extrusion or intrusion in buccal region for 1 millimeter give for us closing or opening the space for 2 millimeter in anterior region. Okay, and how work these appliances? Here is fixed appliance, but also the bands has a special kind of tube for headgear. And look how it works. You see, it push and distalize the molars and close the space in anterior region. Okay, so TPA, transpalatal arch, we can also use. This is the tube for headgear. And when we put this intraoral part of this wire to this tube, here is U-shaped bend, and activate in this direction, we achieve intrusion of molars, upper first molars. Here you can see EPA, transpalatal arch or transpalatal bar. Here we have a special kind of tube, palatal tube, for this transpalatal bar. And our patient, before and after treatment, you should remember that the patient, high angle patient, are still growing. So our growth notification, in fact, we couldn't stop the growth. We couldn't. We can make that the intermaxillary angle will grow not so fast, but it still will grow. So even if we treat the patient, we can expect that during our treatment, the intermaxillary angle will be bigger. But if we don't do it, it will be much, much more bigger. And look, this is this boy after probably 2 years of treatment. He was only sleeping in this appliance. Look at the sulcus, mentolabial sulcus here is you don't see almost this sulcus, and here you see correct mentolabial sulcus after treatment. What it means that there was a little rotation, anterior rotation of lower jaw. This is typical for high angle patient. And deep bite, skeletal deep bite, growing patient. Look here, deep bite, and here after correction. The patient wear a removable appliance. We have a half of lower incisors over bite. Maybe it's not the best result, but patient don't want to wear for all the time this kind of appliance. He used only this kind of removable appliance with the bite plane. Normal appliance, you see the acryl, it should be here. And for appliance, if we have additional bite plane, like here, the acrylic part covered palatal surfaces of all incisor and canine. And how it works, you can see it here. You see, here is a space because so you can see once again when the patient, I will turn off this. Okay, and now we see that incisor had a contact with this acrylic part. So here is a space in buccal region between the opposite tip, and they will erupt. So if they erupt, we observe a correction of the bite in the front anterior region. Okay, and that's all. Do you have a question to these lectures?
No.